Good evening. Good evening, Mom Yvonne. Good evening, Mom Valencia. Good evening, Sis Yvonne. Good evening, Mom Yvonne. Good evening, Mom Valencia.
Good evening. How are you?
Thank you.
Good. Oh, we are waiting for Val. She's coming, but she's on as well. I think
Yeah, I know. I
with
see her.
yeah.
That's beautiful.
So what I'll just do the introduction and then she'll take over and do the whole thing. There she is. Oh, there
Nice.
it's you, it's you, oh, it's you.
Yes.
I thought it was Valencia. Okay.
Uh-huh. So
Yeah,
there
there
you
she is.
go.
Can I just take
Lovely.
this call, please?
Okay, not a
Eh?
problem. We're starting at 1:30 in any case. So this was just me letting
Yeah,
you
to
guys in.
test
Let's
the
wait for
volume.
everybody else
No
and the
problem.
cameras as well to see that if everything is okay. So we'll come back at 1:30 in like 3 minutes. Yeah, the team
No
will be.
problem.
Thank
Thank you
you.
so much. No, we are
Bye.
just testing the sound and everything to make sure that
Awesome.
yeah.
Lovely.
Thank you so much.
Hi, colleagues. I am back on. Okay.
Ebezama nje
Yvonne?
utesta nje uba ebezama utesta ilantuka what do you call this? I-audio ne-video if it's gonna be fine. Yeah. So Val, kuthe yathi yafreeza nje.
Yvonne?
Usharp ngoku. You are
Can you?
sharp ngoku. You are fine. Qala ubufrizile. And I was worried. That's why I switched off our Teams, because I remember Teams was on.
No, I
Hi,
left.
Mom Yvonne. Can I hand you guys over to Utolakele Askis? Hi, Tola, how are you?
Hi, good evening. Good evening, ladies. I'm good. How are you, Sister Nesisa?
Good, thank you. Can I just do intros? So, Mom Yvonne in Valencia, they're from SANPES, the South African National Blood Service. Mom Yvonne, this is our go-to, our guru, our marketing, our everything. Yeah, she's the person for us for the for the webinars, Tolakele. So she's gonna assist with everything basically. So Tola, yeah, there you go. Thank you.
Okay.
Okay.
Thank you.
Thank
Thank you,
you.
Sister Nesisa. Good evening, Valencia and Yvonne. I am Tolagele and I am from marketing. So I am part of the technical team in the background. I'm usually with my colleague Sam, but he won't be joining us today. He's off sick. Um, I guess we are waiting for Dr. Kinoshi or Dr. Burton to join, so they can take you through the process. But from my end, I'll be assisting you with technical checks, right? Ensuring that you are able to present on the platform and that your audio is good and that you are comfortable.
Tola,
All
I did
right.
not
Noted.
give
Thank you very
them
much,
co-host, right?
Tola.
Okay. Thank you. Thank you, Sister Nisisa.
Mm-hmm.
Yeah, because they didn't confirm who's hosting tonight, whether it's Dr. Kinoshi or Dr. Shinas, but Dr. Kinoshi called me earlier today.
Mm-hmm.
Yeah, and I couldn't like pick up his call. So I'm not sure if maybe he wanted to, I don't
Is
know
it?
what he wanted to say.
But
Yeah.
Dr. Shinis is gonna come in. He said that he's gonna come through and join us. So I haven't given the Mam Yvonne and Valencia co-host rights, but when I spoke to Mam Yvonne, she mentioned that Valencia is the one that's gonna present. So I don't know who you're gonna give the co-host rights to, but I hadn't done that as well.
Okay. So we will give both of them the permission to co-host. So co-hosting means you have access to everything. Your audio, I mean, being able to mute yourself, open your own camera, interacting with chat, but you can only use the mute button, muting and unmuting yourself, and your camera button. Please don't touch anything else because you've got permissions to everything. Be careful of that. Just use your camera and your mute button. Okay.
Tola, is it possible that perhaps they can share their presentation with us, with you, perhaps, so that if anything happens, you'll be able to present on on your side for them?
Not a problem. In a while, Sister Nesta, can you give me hosting permission because you are the host, I am co-host. Can
All
you
right.
change? Yeah, can you change there on the side on the panel?
Yeah, I'm doing it now. I've done it.
Okay.
Mm-hmm.
All right.
Why am I the host? Because I'm supposed to be the co-host. Is it
Yes, you
because
are
I'm
now the
early?
co-host.
Thank you. Thanks.
So a co-host has limited permissions um, compared to the person who's actually hosting, because the person who's actually hosting is able to mute people in the background if there's someone speaking in the background. Um, and as a co-host, you won't have that permission, but you have everything else. You can admit people, you can speak to people on the chat box and everything else. But for our presenters tonight, please just be careful of which button you click on the platform. Okay.
Thank you, Carla. Ma'am Yvonne, may you please send us your presentation, please?
Are you able
Uh,
to
Val, since it's Val who will be presenting, the
Mhm.
presentation is with Val. Val, can you
Yes,
respond, please?
I'm not sure if we are able to share presentations. But we'll have to check with the office in the morning because we had in the past we've been told not to share them, but I'll just verify that with management if it's
It's
okay.
okay so it was only for the purpose of this presentation, just in case there's issues. But if your Wi-Fi is strong, then it's okay because usually in the past, our marketing people like Tola, she would normally
Mhm.
display the presentation
Have a
on
second,
for
yes.
your for your sake. But can you just share your presentation for us now, please, so we can see how it looks like?
Okay.
Yeah.
Because you've been made co-host already. Thank you.
Just wanna move the button over here.
Awesome. Wow.
There we go.
Ah, wow.
Um,
This is going to be an interesting topic session. Yeah.
Yes, yes,
Yo,
definitely.
yo. Some of us are already triggered. Ooh, wow.
Mm. And we had this organization, we had you guys over when on the 22nd of April in our office. So we haven't invited you in a while, but now
It was 26th of
um
April.
on the 22nd, yes, your organization did come through to our office to collect some blood. And people actually responded positively. We had almost 20 people that came to donate blood, that donated blood, actually. So I hope our staff is also joining, especially the ones who donated blood. They'll be joining us tonight to learn more about blood donation, and why it's important. Okay, you seem to be familiar with the platform. You don't have any trouble with Zoom.
I don't think I will have. It's just that I'm using the web version. It's kind of
She's an
different in the past
expert.
we used. No, not at
Don't
I
all.
can
worry.
see that.
She's been
I can see
presenting
that.
for more than 10 years.
I can see that.
Yeah, your
I just
presentation
have
looks
a,
good.
Hmm.
oh, thank you. Thank you.
Looks
Amazing.
Yeah,
good.
the web version is a bit different though. Um, we had the systems upgrade here at Sunburst. So with that, there are certain apps that were on our desktops that were taken away, and I just realized this moment that I had to use Zoom, that I no longer have the app.
Oh,
So
Mm,
yeah, no, but I think it will work, the web
yeah,
version for today.
yeah.
Yeah, it will do
And
mostly what we need to do.
and your connectivity is good. Who's presenting?
Yes,
Is it Miss Valencia?
yes, it will be me, and I have a backup network in case there are any problems, but I don't anticipate any.
Yeah,
No,
yeah.
I trust her. I'm relaxed. I'm going to do like this. After I've done the introduction, I'll just sit like this.
No pressure on your side.
no
No
Not at
pressure.
pressure.
all. Not at all.
Wow.
We us
Wow.
we usually host 250 to 600 people every Thursday.
Wow.
Wow.
If your invite gained traction, you should definitely expect almost 600 people to join tonight. Um, our
So it will
Our
increase.
question and answer session is really in depth. We literally take 30 minutes to do the Q&A.
Okay.
So people send their questions on the chat box. Others are able to ask, on the platform so that you have that interaction with your participants. Yeah, people, doctors, we are very popular, I guess, with the number of people we attract every Thursday. They do love Clinix webinars because they're very informative. People get to learn and keep up to date with the new information within the health sector. So, and we always invite quality speakers on our platforms. So, yeah, people are definitely expecting quality,
Quality.
quality presentation, quality information. Yeah, so you will definitely get engagement.
I trust
We are honored.
trust it, trust it, trust it. Quality. That's number one. I trust her.
Yes,
She's my colleague.
yes, of
Yes.
course.
Yeah.
She's very good. I believe you me, a perfectionist. That's why I decided not to spoil her with that black dot because me, I'm gonna spoil the thing. So she
Yeah.
likes to be in control. So I said, okay, do
Ah,
it, do it, do it.
that doesn't sound like a compliment, though.
It is a compliment.
It is. It is. Your colleague trusts you. She
I
really
do,
believes
Shem. I
in
trust her. If it was someone else, I was gonna let's do it together just in case. But now because it's
Yeah.
her, I'm relaxed. I'm gonna play with my
Yeah.
phone on
But
YouTube. By the
but
way,
be
I'm
ready.
joking. I'm joking.
You must be ready in the background for Q&A
No.
because
Both of
Yes,
us, we will.
yes.
No, we've been doing this. We do have what you call it, lecture series, like tomorrow morning, 8 till 9. We do it every Fridays, except when it's weekends. We do
oh,
that.
is it? Is it?
Yeah, we do have attendance of like the number which you're talking about.
Yeah.
So she will be presenting again the same topic on the 29th. Same thing for nation. Nation. So
And
that's why she's so chilled. She's not nervous at all.
Yeah. Tola, I think Dr. Burton is in. I'm not sure
Okay.
who's in, whether it's Dr. Kenosha or Dr. Burton.
This is me speaking.
There
I don't want to
there
interrupt
we
the
go.
ladies. I am enjoying the conversation. I think we are going to be rich. We're going to take this around the world because you're all confident, you're all excited, you know what you're doing. So I love it.
You know what, Doc? I'm excited because I'm not presenting.
Yvonne, and that's what I said when I saw you putting the presentation forward. I said to Sister Nasisa, "Is that the same Yvonne that presented the last time?" And then she says, "Yeah, it's her." And now you're all disappointing. I think, Tolakele, let's cancel tonight, please.
yeah.
Okay, okay. So, so Yvonne, are
Okay,
you?
Doc.
Hi, good day, good day, good day. All right. So
Good
who's
evening,
presenting tonight?
Doc.
It's Valencia only. I,
Ah,
I want you
Yes.
to hear another voice, not my sharp voice.
ah.
She has a
I love.
beautiful romantic voice.
Also, you come with a beautiful.
Mine is sharp. Is people they run away. Yeah.
Yeah, no, it's gonna be a good evening. Yeah, it's gonna be a good evening tonight, definitely. I'm personally a donor, so I am really looking forward to it. Because I feel like I donate out of doing the right thing. Um, because I know so many things happen, like accidents happen, people need blood, people are sick out there, they need blood, and I am healthy, and therefore why not,
That's
Yeah.
perfect. What's your
But
blood group? That's your blood group.
I am AB plus.
Okay.
Okay. Okay.
Yeah, I
You
know I give
donating
to
blood?
everyone.
Ah,
Do I?
eh?
No. I receive from everyone, but I only give to the AB.
Yes.
Perfect.
Yeah,
Yes. I
You
thought
know
you had
your
a
blood group.
yeah. Then,
Do,
oh, somewhere
you
here.
donating blood or platelets?
Sorry,
Are you donating blood or platelets or plasmas?
am I donating blood or
Are you donating blood or platelets or plasma? You're donating
what?
blood only. Okay,
Yes.
you're donating the whole blood. Okay, it's fine.
Yeah.
Okay.
What's the other
No,
option?
there is another
Like,
option if you want to be treated like a queen. Yeah, you go
Ah,
for another level, which is called platelets. You'll be treated there like this.
okay. No, I've never. I haven't heard of that.
Where do you stay in Joburg?
I'm in CBD.
CPD. The closest I'll look for it, the closest fixed center, you go there. You'll see what I'm talking about.
Okay.
What they do, they take your blood, it goes to a centrifuge, they take what they want, either platelet or plasma, and they give you back your blood.
Oh, they extract those things, the plasma from the blood.
Vampires. Tolakele, come on. We know you watch these movies. That's what they do. They take the blood.
Well spoken.
It's obvious.
I'm sitting here confused. I'm like, what?
Oh, she's confused now. What? Yeah, this is cool.
I'm sorry. I'm sorry. I continue with what you are doing. It's okay. Wanted to show you another one.
Okay. Let me
Thank you,
quickly run through the logistics, please. Thank you so much for joining us. I am truly honored and it's a great pleasure for me that we are doing this. Last time, the only person that was talking was Yvonne. No one could ask questions. We were all had to sit there and suffer. So it was really. Who was talking? Who was it the last? Who's presenting tonight? You, Valencia.
Yes.
Oh, okay.
I'm not the one with the network problem, right?
Yeah, no, I think, yeah, he's stuck. He got stuck. Sister Nisisa, are you there?
Yeah, I'm here.
Yeah,
I
I
think
see
it's
that.
Doc's network.
No,
Doc, you were
the
stuck.
electricity went off.
Oh, sorry. Okay.
What happened?
You must check your, what is it called? The danger box in your house there or if you're in the office.
The DB box.
Yeah. Tell her, are you still in the office? Tell her, Kele,
Yes, Sister Nisisa.
are you still in the office?
No, I'm at my place. I'm at
Oh,
home.
okay. Oh,
Yeah. Okay.
I think Doc is still in the
Like,
office.
no. Can you all hear me?
We
Yes.
can hear you, but your image is very dark.
I know because I don't know. Maybe Telkom switched off my light at home. What? See, this is me now.
Okay,
Okay.
Doc.
So, Sister Nasisa, you know how you said you always wanted to do these webinars?
No, no.
Okay. Um, Okay, so anyways, the whole idea is when this eventually goes on, is that I'm going to do introductions,
Mhm.
and just say who you are, what you're all about, and then do some housekeeping rules, and then you'll present. You can keep your camera on. Keeps it interesting for people that are on the call. I'm gonna see if I can join on my phone. And then so people are able to participate and they'll see you. And then at the end, don't read the questions in the chat. You just present, and then at the end we'll go through the questions, and we'll just go through that, and we'll guide you through the whole exercise. And Tolakele will send you a gift. But since Yvonne is not presenting, so there's been nothing sent her way. So so don't worry about that. We'll make arrangements for her to get one too, because you're both speakers. And so just have fun. We tend to, see these things work out quite well. The attendance, see, we got 16 people so far, and I'm sure that they were all there. I'm gonna see if I can switch to my phone. I've never used my phone for these webinars. What happened? Okay. Anyone else? Yeah.
Valencia, is it possible that you can display your presentation? Just the
Yes.
first part, yeah, so that when Doc starts, people come into your first page of your presentation.
Yes, I can do that. All right.
And then also, I just wanted to ask, Ma'am Yvonne, because you're not presenting, I'm assuming you're going to switch off your video, right? Then it's going to be only Ma'am Valencia's one, me. Thank you.
Yes. And then it looks like Doc is taking care of introductions. So it means that I'll just have to tell the guests that Yvonne and I are doing questions later together.
I'm sure Doc is going to cover that in the introductions, unless if there's something that you'd like to tell Doc, I'm sure you can tell him because we still have time now. There, Doc
Okay.
is back.
Yes, that's just that we will be doing the Q&A, because when we get to the Q&A session, they may hear a voice they haven't heard this evening and get a bit confused.
No, they won't get confused. You just put on your camera and then we'll do the introduction.
Oh, okay. All right.
So, I don't know. I put on my camera, but I'm sure you can't see me, right? I can't see myself.
We
I
can
am
see you.
sharing.
You see me,
Yes,
but
we
it's
can see
dark
you.
in the place. But it must be so dark. What do I look like?
You look like Dr. Burton. She is the normal.
Thank you. That's
Tola.
good.
Yes. Are
How
you
does
are you
it-
joining through your phone, Doc?
I am, yeah, because the electricity decided to leave us.
Hmm.
Wait, you know what? Let me do something else. I'll use my other laptop.
Okay.
I'll just email it to myself. Hmm. Do you think Sam has anything to do with this?
No, I don't.
He-
Poor
He's
Sam.
gone.
He's still with us. It's just that he's off sick.
Oh, he's sick. I was going to blame him. So fortunately, he hasn't left. Okay, I'm going to email it to myself. And I don't even have notifications. I think, Sister Nasisa, this is a perfect time for you to practice doing these. So I think just take over and run with it from here. It doesn't sound like a yes to me. It's insane. Oh, okay. Oh. Mm, mm, mm. So, Yvonne and Valencia, you see, this is why we do these things up front, so that we don't end up rushing and stressing. Is Nero on the call?
Doc,
Evening, Doc. Yes, I'm on the call.
Dr. Barton, do you know why you are struggling with your network?
Yes, I
Because
know.
because you said something bad about me, ne? So it was a way of punishment. Eh? One strike.
Okay, I'm so sorry. I'm so sorry, Vaughn. You know, the presentations were remarkable. You covered so much phenomenal information. We learned so much. We're all enlightened. You know, if it wasn't for you, you know, all of us would have been dead by now. So yeah, does it help? No, let's see what happens now. Okay. You are unforgiving, huh? All right. So we have 36 people that are on here. Now I know you can do this, so I think I'm just going to leave it over to you.
Ish, it's an unprepared speech type of vibes, though.
As long as your videos are young, strong, dashing looking young men, so I don't think they'll care about too much about what you're saying. They'll see. That's all right. We got the whole 3 minutes to sort this out. It's more than enough time. I hear my landlord trying to sort out this electricity. So Sister Nasisa,
Yes, Doc.
when you said I looked like the normal me, Dr. Burton, were you- but was the light awkward? Okay, I see my
No,
laptop
it
is.
wasn't. Which is why I said to Talagele, please tell Doc. Because I was gonna say to Tala, just tell him how you look like, because I didn't say anything wrong.
Oh, so it didn't look like me. Okay, please turn on my video and turn on my audio. I'm not using the organization's connections. So if you could please either make me a co-host or if you can please turn on mine.
Tola?
You can't turn the video. You can't turn the video from your side.
I am, yeah, make me a co-host, please. I'm not using my company laptop. I'm using my private one. So please, yeah. Are you sleeping already? What's happening?
You are a co-host. You should
No.
be able to. Yes.
Yes, because I am currently on my cell phone. Let me do that. You know what I'm talking about?
There you go. Your video's on.
Yes, because
And
this
there's
is from
nothing
my cell
wrong with
phone.
that.
Is there nothing
Yeah.
wrong with my video? You see me
So keep it steady.
clearly.
Keep
Okay,
it steady.
hold
Yeah.
on.
Mhm.
Okay, let's try again. I even brought a
Yeah.
jacket this time for the occasion. Can you see me clearly, or do I need to turn this light a little bit brighter?
Come a bit closer, as
I must
if you
come
are
closer.
leaning. Yeah. Just yeah. That's good. Just don't allow yourself to lean back too much because that
Am I
position,
exactly where I'm supposed to be right now?
yeah, you look good. Yeah, that position, how you seated is good, Doc.
I won't move.
Yes, please.
Is it?
Yeah, just yeah, don't lean back because you
I
tend
am
to.
sitting upright. My chair is everything is just perfect.
So practically it's freeze. Okay, don't move, it's a
Yeah,
freeze.
that's
I'm
yeah, you look good,
frozen.
Doc. Yeah.
I'm not even moving my lips. Am I still fine?
Yes, yes, fine.
This
You
is
good.
so awkward. Okay,
with
let's
the
give it
phone,
one more
hey?
minute. Let's give it one more minute and we'll let everybody else in. Awkward, yeah. I'm not moving. Okay. When it says 6:02, we'll let everybody in. Valencia, you presenting tonight, right? So I
Yes,
don't make
that's
up
correct.
story. And you seated, but she's leaning back. Look at her on the couch. What is happening?
No, but she's closer to the video. Like we can see her. So with the thing is, you see your phone. It's
Someone
the
entered the people in. People are
Yeah,
coming in.
you
no.
can let
As
you
soon as
can
Doc is
you,
ready.
I'm
But I
ready. You
see,
can let people. I'm ready.
yeah.
Yeah, you can go ahead. Let everyone in. Thank you.
All right. Thank you.
Oh, I'm putting on a black jacket. It's bright. Maybe not today.
Recording in progress.
Hi, good evening, ladies and gentlemen. Thank you once more for joining us on one of these presentations that are held every Thursday by the Clinix Health Group. We want to say a warm welcome also to our colleagues from the South African National Blood Services. In particular, we want to welcome Valencia Nkambule, who is here joining us this evening, as well as one of our colleagues, Yvonne Nyakaza. Yvonne also gave us her CV. Initially, we thought both of them were presenting, but Yvonne sprung a surprise on us that she was here just to answer all the difficult questions at the end of tonight's presentation. So, Yvonne, maybe you want to show your face briefly while we are going to introduce and welcome everybody onto the platform, and then we'll cover a number of housekeeping rules. Ladies and gentlemen, yeah, some time back, Yvonne, who you see at the bottom there with those airline type of pilot headgear that she's got going on. So she joined us and she did a presentation on behalf of the South African National Blood Services. There was a concern raised by Professor Lundgren, which we'll talk about a little bit later during the course of this evening. But again, as our colleagues are joining on and logging onto the presentation, I just want to say warm and hearty welcome to everybody. I know that out here in Johannesburg, it's kind of cold, it's freezing. And just for the fun of it, Eskom decided to turn off our electricity in the area. So I hope the network holds and that you're able to see me clearly and hear me audibly. And as I tend to repeat on a weekly basis, I know that you received. Thank you so much for the confirmation, colleagues on the side. So yeah, if you could please just let me know if there's any difficulties in hearing or seeing me, and then one of my colleagues may jump in the back. So just part of the weekly indications, please. I hope that you are able to click on the link and you were able to register. And if you received the link from a colleague who had registered, please make sure that you do register so that you can receive your CPD points and other points, especially, in fact, even the SANC. Now, you don't have to send us your South African National or Nursing Council's numbers on the side on the chat anymore. You will be receiving those certificates automatically from the team, where you can also be receiving your CPD points. As you know, the Clinix Health Group is one of four organizations that is able to provide you with CPD points for your nurses as well. And then, of course, while the presentation is going ahead, your audio as well as your visuals will be disabled. And then towards the end or during the course of the presentation, feel free to ask any questions that you would like to pose to our two presenters today, both Valencia as well as Yvonne towards the end. You've put the questions in the chat, or as I said at the end, feel free, you can even put your hands up. and we will unmute you, and you can ask the question directly and speak and raise it with the colleagues that are presenting to us this evening. Xolisa, I see Xolisa Machine. What are you saying? Hello to everyone. Good evening and welcome to you too. So, ladies and gentlemen, some time back, during one of our clinical risk committee meetings at Clinix Health Group, there was a concern raised by Professor Chris Lundgren. I know that you all know she's an esteemed professor in the specialty in the field of anesthesiology, and she was the head there at Chris Hani Baragwanath Hospital. And she wanted to find out if doctors were aware that the fresh frozen plasma was no longer arriving at the hospital in a frozen state. And in fact, there were dates and times when it was expiring. And she was concerned that some colleagues were taking the information, or they would take the blood products and they would actually refreeze it if they had not used it, and then they would scratch it out and put a new date for when the product was due to be expiring. And so, which is a major concern. And so Yvonne Nyakaza came and presented at the Clinix Health Group, and she said this is a serious violation in terms of clinical safety. And so that's how we got to know each other. So Yvonne, I know you're going to be in the background tonight, though. It's Valencia, who is going to give a brief introduction of herself. Valencia, I believe you are great at what you are doing, and we really welcome you. Everybody's really excited to hear your presentation this evening. And towards the end, as I said, we'll ask a number of questions, all the difficult ones for Yvonne, and then we will be able to move to the next section. I know you're so excited. Everybody, good evening once more. And we look forward to your presentation, Valencia. And I'll be right here with you. Please leave your camera on so everybody can see who you are. And I'm sure it will be an engaging, enlightening, and informative presentation. We thank you for this evening. Welcome once more to all our colleagues. Please welcome and please go ahead. Thank you so very much. Thank you. I'm also very
Thank you very
excited.
much, Dr. Barton. All right. Oh, what a very warm welcome, and we are honored to be part of this proceedings today. My name is Valencia Nkambule. I am a medical technologist by profession. I am specialized in blood transfusion, which can be broken down into the collection side of blood, although not as much. But then I become more knowledgeable with the processing, the banking, and the issuing of blood. And as a hospital liaison officer, just as Ms. Nyakaza, we do stakeholder engagement. So we have a bit of that customer services, and we do this type of presentations. It is a great honor for me to collaborate with Clinix Group. I have somebody who works for you there, whom I consider a best friend, but I know it's all in my head. But because I admire her so much, I hope that she's also joining today. So today I want to talk to you about blood and blood products and the ordering priorities as it pertains to making a request from the blood bank. So we have our own version of the attendance register, where not only that, but if you scan this QR code, which we are going to show again at the end, you will see here on the side, you will also be able to download our clinical guideline for the use of blood and blood products, and you can have that available in your own mobile device or on your desktop if that's how you're going to share the link. And then also we have a navigation to a safe blood transfusion, which used to have a state price list. 2025, the link remains active. We do not yet have the price list publicly available, published that over here. So the link there, the links. But if you were to bookmark this in case you are not able to download it directly at the moment, or you want to revisit again, you will find the link is maintained and keeps updating in terms of where it redirects you. Right. So for tonight, our objectives will be to discuss informed consent as it pertains to requesting blood and blood products. We are also going to look at blood specimen collection and storage. I'll take you through the blood requisition form, the ordering priorities, as well as the blood products that are available. And then there's an invitation, which is also linked to the previous QR code to a lecture series, where we also at SNBS run a similar platform, right, where we cover different topics, including this one that I'm doing today. So informed consent is very important for requesting blood, and it is the responsibility of the treating doctor, the one who is ordering this blood, to discuss with the patient. And it is important that as a doctor making this request and having this discussion with your patient, you also stay up to date with your transfusion knowledge, which is part of the reason why we created what we call the lecture series at the South African National Blood Services, where we can reach more of our colleagues that are using our blood products on a national scale, right? And it is important that we give the patient informed consent. It's an ethical thing because it is actually the patient's right to consent to any treatment that they are receiving from us as healthcare workers. And it will protect you as the doctor from litigation which may happen as a result of the blood transfusion. Also, the hospital where this blood transfusion is performed will also enjoy the protection of the informed consent. Obviously, if we are not negligent, we do things correctly according to how we are supposed to do them. Just a note that if a doctor fails to give a patient informed consent for transfusion, they may be found that guilty of negligence, even if the clinical need was a true indication for using the blood product. So we need to get it as part of our culture, if it's not already in place, that we discuss the blood products with the patients and the possible risk that may come with them, right? During this informed consent, it is important that you specify the particular service that the patient is consenting to. As we go through this list, you will see that we have different types of blood products. And when we do a talk on adverse events as they relate to blood transfusion, maybe in the future when we come back here, we will be covering that topic, or we can ask one of our doctors to come and present those topics. So those adverse events that relate to blood transfusion, they're going to be different for different blood products. So it must be then noted specifically what it is that the patient is consenting for, or to consenting to be transfused with, right? And when we also speak at the level of the understanding of organ, I know certain words can be very second nature to us, such as sepsis, for an example. You don't think that you are being too complex when you use such a word. But to a patient who is specialized in banking and only sees a doctor once a year, that may not be a word that they are familiar with. That would be an example of a situation where we are not using the level of understanding of our patient. So let us be cognizant that the patient may not understand some of the words that we are using, and that there should be, of course, a witness to the consent, and a patient does have a right to refuse the treatment. And then in a non-coercive way, we need to help our patient understand what could be the consequence of the refusal of the treatment. And during this informed consent discussion, you're deriving from the blood products, you'll be talking to these blood products, and under the risk of a set of transfusion adverse age collectively, right? Because some signs that the patient has rejected a transfusion can show up 10 days after the patient was transfused. Any instances, or in many clinical settings, and this happens, the patient would have been discharged. So we need to make sure that we are sending the patient home equipped with information. The body, it could indicate that it was related to the transfusion, and for the patient to come back to us to be managed further. It is not informed consent if we do not introduce alternatives to the products that we are recommending for the patient if these are indeed available for the patient. And the likelihood of success with this treatment planned interventions and the recuperation time for the patient, because when the patient is receiving care, they are not then at home, or they're not at work receiving or earning their income. So we need to let them know, as well as the costs that are associated with the blood transfusion. If you are somebody who is like me, who tends to be very obsessed with visiting the HPCSA website, you would have found that somewhere on this website, they publish findings against practitioner. And you will be surprised how many times, as practitioners, our patients bring up complaints about us because we did not tell them beforehand about the cost. And the council always rules against the practitioner, saying that you failed to give your patient informed consent about the costs. So in order for us to be able to have this meaningful discussion with the patient, we also need to have access to the certificate, as I said, with that link, please, so that we are very transparent to this particular service of blood, specimen collection and storage. So now you've spoken to your patient, they've consented to the transfusion. You now have to start the process of ordering these products for the patient. It's important that the prescribing doctor identify the patient for whom this request is being made, right? The patient that needs to be given this blood. Procedure must be followed in making sure that when you say, maybe as a doctor, you're giving an instruction to a nurse that we need to transfuse a particular patient, that nurse actually understands which patient we are talking about. One of the services that we offer our colleagues and our stakeholders as it pertains to blood transfusion services is education at a facility after there has been an adverse event or there has been an incident. And what we have seen, especially in my area last year, we had a lot of patient misidentification that resulted in patients having reactions. So we always need to make sure that patients are correctly identified, as you do when you are requesting for blood, maybe from Lancet or from Ampath, or if you have your own laboratory at that facility. You will identify the patient during specimen collection. But with blood products, we have a second phase of patient identification. This is when you have now received your blood products from the blood bank and you are ready to start the transfusion. And what we always say to our stakeholders, re-identify the patient again by the patient's bedside, following the very same protocol that you followed when you identified the patient to collect the specimen. All right. Correctly label the specimen with the patient details. Check the expiry date on the tube. The blood bank will not process or receive tubes that are expired, and make sure that you use that 6 ml EDTA that has a label around it. Make sure that you've collected an adequate volume for the testing and the compatibility testing. The good thing about this, what I need to make clear here, is that with the South African National Blood Services of blood for your patient, using this 2 hours from the time that you as an enough sample, so that particularly if they are doing a manual process, to record the date and time of specimen from that time. Sign on the form, send the request to store the requisition in the fridge until such a time that the courier becomes available. Then you give that specimen over to them, right? As I said, we will take it as long as it's not older than 72 hours, right? Record on the blood request form, record the blood request in the patient's file. I will tell you a bit of a joke as I'm checking the time, or a story that happened in actual life, where many doctors in a hospital consulted the same patient over several days. Every one of them kept on recommending that the patient receive 1 unit, and the 1 unit was the specimen was collected, the blood was ordered, requesting that 1 unit. However, nobody noted it in the patient's file, and the next day somebody else did the same thing, up until 7 days, where 7 1 unit orders were sitting in the fridge with the patient details. So information is very, very crucial in our operations. Now, this is the request form that you fill in when you are requesting for blood and blood products. Section 1 is where we put the patient's personal information. So this does not really much apply to the private sector as much, because you do use those labels, but it is important that the specimen will contain the patient's full details, such as their full name, their date of birth, their gender, the hospital where they are located, their age, financial classification or the medical aid details, the hospital number, as well as the ward within the hospital where they are located, right? Those all form part of patient identity. They should be on the form, and they should match what we have on the specimen tube. If they do not, we reject the requisition, assuming that a mistake was made in patient identification, and for patient safety, we cannot process such a specimen. Even if you call and you say, I am certain that I took the blood from Yvonne Nyakaza, I just made a mistake by putting the sticker of Valencia Nkambule, we will not process the specimen. We will kindly and respectfully ask you to go and start the process all over again. Right. Section 2 and 3 of our form is where we list our blood and blood products, right? Their volume, and then you will indicate the number and the date and time that you require us to make the blood available for you, right? And under here, a blood administration set can be requested, and with some facilities, we the blood bank will keep blood pack with and without anticoagulant, right? Then here under the section that says type of cross-match, it's where then now you indicate what we call your ordering priorities. You communicate to us, I want how fast do I want this blood, or how I want you to handle this requisition. If you choose standard, right, or you write on the form as soon as possible, it says to me that I will process this blood within 2 hours, right? I will do the full cross-match, find the blood compatible, and then release it over to your patient. However, if you tick this area here under emergency, it means that you want me to do an emergency cross-match. An emergency cross-match is called a partial cross-match, meaning that I will not do all the testing. I will skip some of it, prioritize getting the blood to you, and then I will remain in the blood bank to do the rest of the test. This therefore means that I may learn that your blood is the blood that I've given you, 1 or 2 or whatever number of units, are not compatible to your patient, because it only became apparent to me when I did the second phase of the cross match, right? So when you order blood as an emergency, first of all, always ask our colleagues, please make sure that it is indeed an emergency. It is not a way of making the blood bank work faster, right? Because it comes with actual risks to the patient. We also take it upon ourselves to label the blood as partially cross-matched as well, right? So that you know that this is a high-risk product. You may learn of incompatibility after you start the transfusion. Secondly, have an open line of communication, because we may need to call you and give you very urgent information about these blood products. Under the section where we have none, we see that some certain products, such as platelets, are non-cross-match products, right? This means that we can give you a platelet, we can give you 2 platelets without necessarily finding out the patient's blood group. We can do that with fresh frozen plasma up to 4 units. If you need 5 or more, then we need to cross-match the patient's blood to that particular requisition. And another form of a non-cross-match setup that we have, or blood product that we have, is with the emergency blood fridge, right? The one that you keep at your facility. That unit, that fridge contains units that have not been cross-matched for any patient. We are using O, which is a universal donor, but there are irregular antibodies, as we put them, or as we put it, that may exist in the patient's body because of previous transfusion and previous pregnancies, that may actually make that blood not compatible to the patient. And what we always tell our stakeholders, the clinicians, to exercise even more caution as it comes to the use of non-cross-match blood, being that emergency blood fridge, because of that incompatibility. And we actually look at our hospitals, and those that use more of this blood, we classify them as high risk or the high using facilities, and we actually make it a point that we reach them. As of last year's performance metrics, we needed to reach them in a virtual platform twice a year to make sure that their colleagues, they are knowledgeable about the risks that pertain to the use of non-cross-match blood. Lastly, type and screen. When you say, or you select type and screen, it means that you are not yet ordering, right? But you want us to be ready to receive your order. You fill in the form, you give a specimen, we do the first phase of testing. If there are no irregular antibodies for that particular patient, we hold on to the specimen for 72 hours, during which you may call us at any time and ask for a conversion of the type and screen. And how do you do that? You call and you say, I need 2 units of RPCs for this particular patient. We take the message down, we put it at the back of the form, and then we prepare units for your patient, right? Section 4 looks at the clinical information. With the clinical information is where we expect to see the diagnosis written out in full, as well as now the ICD-10 code for that particular diagnosis. The diagnosis we ask of you because it is very important in informing testing type that needs to be done for your patient, because we have electronic version testing where the unit finally the unit is selected for the patient by our system. But then we also have a manual testing where for certain high-risk patients it is mandatory to do, such as patient with sickle cell disease, right? So the system knows that if you put in the code for sickle cell disease, right, it knows automatically to demand that manual testing be done for that patient, because the guideline is, or the standard is, do manual testing all the time. Secondly, the diagnosis informs the type of blood product. It informs the indications, if I can say so, of the particular blood product. I do not expect you to go through the clinical guideline and remember each and everything, but if you put the diagnosis and according to the clinical guideline, a certain type of product, for example, leukodepleted, is required for your patient, then it is we can call and say, doctor, do you want to continue with how you ordered it, or would you like to do what is recommended according to the clinical guideline, right? So please put that diagnosis there. And number 3, There are certain diagnoses that the blood bank cannot handle, such as when patients have viral hemorrhagic fevers. The blood bank does not have the necessary safety level to handle such a specimen. So if in fact, we tell you, don't collect it at all, just tell us, fill in the form and tell us. But if you forgot and you did submit a specimen, then the blood bank will know to take that specimen, dispose of it, close the bin, cover it up, and call our waste collector to go and to come and collect the waste on the very same day and disinfect the lab. Right. So that information is very pertinent, that it is also shared with us. I've seen in the past that colleagues were feeling sort of reluctant to tell us the patient's diagnosis. Right. And then the hemoglobin count for the patient, the platelet count for the patient as well, the reason why the patient is being transfused, if the patient has been pregnant before, if the patient has received blood or bone marrow before, when have they, or the diagnostic category, when was the patient pregnant. We ask for all this information. And the reason we ask you for all this information, because pregnancy and previous transfusions are usually the sensitizing events for patients, meaning that having been exposed to the blood of another person, whether it's because the mother is being exposed to the blood of the newborn, or the patient was previously exposed to blood of a donor, the body of the patient can then go on to make what the irregular antibodies or the allo antibodies, and those in the future may make the patient reject the blood transfusion, right? Even within the population that is the patient's own blood group. That is why we are vigilant for this, and we ask you to please also share the information where such a risk exists. Number 5 is our warning. Under this warning, we tell you that blood may
Good evening, colleagues. I think my colleague there has a signal problem. I do apologize for that. Let me see if I can continue. Okay. She's back
Thank you,
now.
Ms. Yvonne.
Okay. Val, you have a signal problem, sweetheart. You keep on breaking. Can you please check? Yeah, go back. You can present for this slide. Thank you.
Right, let me share again. I truly apologize. Where we are. Oh, can you please tell me where was I, Yvonne? Was I on the
sign about
warning slide?
warning sign.
Yes,
Number
okay,
5.
okay.
Yeah.
All right. Right here. All right. Colleagues, yes, I was on the slide myself from the current go. Okay. So I was saying here that the World Health Organization does recommend that every country get to a point where they are collecting blood from donors that are not paid to donate, because these donors, because of altruistic reasons, they are actually not donating because they are looking to benefit something, especially something in terms of finances. So they tend to be more honest when it comes to answering screening questions that may even disqualify them to donate, because being disqualified to donate does not mean losing an opportunity to make money. So they tend to be very more honest, right? And it tells you that we test the blood products. We always make sure we test the blood products, and we only release them to you when they are negative for these markers. We have two types of testing, serological and nucleic acid testing. We test for HIV-1, we test for HIV-2, we test for hepatitis B surface antigen, we also test for hepatitis C as well as syphilis. When we say when these markers are negative, we mean those particular markers. But those are not the only risks, however, we will understand that can be carried those are not the only risk disease that can be transmitted via transfusion. So all the other ones you learned about from college, they are still a risk to your patient. So during that informed consent discussion, they also need to be spoken about, right? So lastly, in bold and red, it does say the doctor who's ordering this blood must take this into consideration and is responsible for discussing the benefits and the potential risk of this therapy with the patient and for obtaining informed consent for the transfusion. All transfusions must be medically justifiable and alternatives to blood transfusions must be considered. And then as the requesting doctor, you go on to sign your surname, your signature, your contact number. Where it says practice number, it's your personal MP number issued by the HPCSA. But if you, the doctor, are the same person that collected the specimen, you just need to fill in the section that says date and time over here on the form. However, if the specimen was collected by another, then that individual will have to fill in the rest of the session over here. If you have any comments for the blood bank, you're more than welcome to put them here under the comment section. Right. So then these are the blood and the blood products that we have. I'm going to go through these ones very fast because I'm looking at the time. I was told that we must give enough time for Q&A. And secondly, the link or the QR code that I showed at the beginning contains clinical guidelines which discusses them in greater detail. In a nutshell, we have red cell product, plasma products, as well as plasma products. We have some regular which are available at the blood bank, and then we have some special products that we must make prior arrangement to obtain. Firstly, we have our red cell concentrate, which is the standard adult red cell concentrate, right? Which these are the information about storage, volume, and shelf life, right? I'm going to focus more on the indications. We use this particular product in cases where we want to increase oxygen delivery to the patient's cells or the tissues, as we may want to in cases where patients are anemic or there is acute blood loss or bone marrow failure. And then we have leukodepleted red cell concentrates, right? These are it's the same product as this one, but that has been filtered to remove the white blood cells. And this one is indicated in situations where a patient has had a non-hemolytic transfusion reaction. It is the recommended product for repeated transfusions, such as patients with chronic kidney disease or for patients who are receiving stem cell transplant. This is why I said to you, it is critical that you share with us your patient's diagnosis. That clinical information section is very important because if your patient falls within this category, then you have not selected this unit, then we can actually call you to talk to you about using this one, right? And then we have pediatric red cell concentrate, 75 mils. In fact, this when we split one adult into 3, it becomes an infant red cell concentrate, 75 mils. This is the rate at which you can give it to the patient, the impact it can have on the patient's HB. The indications for pediatric red cells is similar to those of an adult. Then we have our fresh frozen plasma. This is the parameter over here on volume and storage. If it is indeed frozen, right, it can be kept at the blood bank for 1 year, but with all products, we always say to our clinicians, please use within 72 hours. If you have not used it, it's best that it comes back to us at the blood bank to be destroyed instead of it just sitting there at the ward, because then they could also wrong blood can be given to the wrong patients. It just increases the risk. And the indications would be in cases of massive transfusions where patients have vitamin K deficiency that is making them bleed, or want to reverse the effect of warfarin, or patients have developed DIC. We also have it available for peds in a smaller volume with more pediatric aligned indications. Then we have cryoprecipitate, which is produced from FFP, a smaller volume. It's rich in this floating factors. It's also very rich in fibrinogen. It gets used in cases where these factors are low, or it also gets incorporated when we are doing massive transfusions as well as in DIC, because you can think of it as a concentrated FFP. Then for platelets, we have two types. We have apheresis platelet as well as pooled platelets. And the difference with the apheresis platelets, though they can be used in cases of thrombocytopenia, but they are more focusing on certain patients, such as patients who are for oncology, right? And with platelets, what I want to emphasize, same applies to the pooled platelets, is their storage. Platelets must be kept between 20 and 24 degrees Celsius. They have a shelf life of 5 days. They must be kept agitated all the time. They must never go into the fridge, right? Whole blood is our first special product. We use it mainly in exchange transfusion, although our clinical guideline will also talk about massive hemorrhage and severe burns, but this product is not kept at the blood bank, meaning that if you are having these emergencies, then it is best to use the fractionated blood product. You can order FFPs, you can order platelets, you can order plasma from the blood bank. Those ones are readily available, just that the whole blood can be contraindicated for certain patients, especially those who can be at risk of circulatory overload because maybe they are having cardiac failures, right? So when you're using this volume, this product, because of the volume, it has that contraindication. Then we have wash rectal concentrates, which is we take the rectals and we wash them because the patient has certain risks. And those indications are when a patient has had severe recurring allergic transfusion reactions that are not prevented by the use of antihistamines, or patients that are known to be IgA deficient and they have made antibodies to IgA antibodies, or neonates with T-activated red cells. This is after certain bacterial infections eat away at certain structures on the surface of the red cell, exposing what is called the T antigen, which many adults may have the anti-T antibody. And these adults in this particular case could also include the people that donated this blood. Or when we have stored gamma irradiated red cells, because if we do gamma irradiation, as it's indicated in the cases that we're going to talk about in the next slide, right, we need to use those blood products as soon as possible, because while irradiation will not destroy the red cell and it's aimed at the white blood cell, but it does interfere with the integrity of the membrane. As it sits, it leaks out more and more potassium and it can accumulate, right? And irradiation, or the use of irradiated products, is recommended in cases where we are giving blood to blood relatives, or we have done HLA matching for platelets because this patient is experiencing platelet refractory. Then we have to go and do HLA matching to find platelets that can be matched to the patient's own HLAs, right? All exchange transfusions, unless radiation is going to delay treatment of the patient. Intrauterine transfusions, it is recommended we irradiate. And allogenic bone marrow transplant, we irradiate. It's recommended we irradiate patients receiving stem cells, Piran analogs, Hodgkin disease. It is recommended that we irradiate their product. Right. Important to remember, we have a doctor on call 24/7 at the South African National Blood Services. If you're experiencing difficulty, get in touch with your blood bank, and the blood bank will then get in touch with the doctor, and the doctor would, the blood bank and the doctor will first discuss the case, and then that doctor at the blood bank can then call you back to discuss your patient or to assist you, right? Which is very important. That is why we ask for your full cell phone number on that form so that we can reach you. Right. Once again, this is the link that will redirect you to the link in bio with the clinical guidelines available for you there, as well as our own attendance register, so that our boss can be very generous with us and give us over time, and you can prove where we were at this particular time. Colleagues, thank you very much for your attention. I've reached the end of my presentation. Thank you.
Thanks, Ms. Nkambule. Well done, sweetheart. You've done your best. Well done. I'm so proud of you. For a change, I was not presenting, eh? Thank you for presenting everything. Okay, there's the question is asking Val, could you please explain the procedure that should be followed when returning unused blood to the blood bank?
Okay. So the blood that has not been used can just be taken from the ward and given to the blood bank. However, many hospitals actually want to monitor this. Some of them consider it wastage. So, okay, what we ask is that can you please give us the reason why the blood is being returned, and then we can destroy the blood and then capture the reason. But then the hospitals would also want to maybe have a form where they write the details of the patient, the blood product, and why it is being returned, because they are monitoring. They're using this, especially in the public sector. They're using this as a monitoring tool. But on our side, we just ask you, please tell us why the blood is being returned. In many instances, some colleagues just say, hey, they just asked me to drop this product by the blood bank and they pass. But that's what we need is the reason. We appreciate having the reason. But this, the reason for return, however, is monitored usually by the hospital because it has a cost implication. But there is no set procedure per se.
Thank you, Val. Can I just share with you? There's a presentation which I did last time. It shows, just take a picture so that you can share with the colleagues. Can you stop sharing, Val? Thank you, my love. And then this is the picture which I want to, I don't know if you can see it. Can you, did I press share? Can you see it?
Yes, please.
Okay, this is the picture which I normally share when people are asking about what do I do with a blood product not transfused to the patient. First, you write the reason. That's your step one there on the label. Why did you not transfuse the blood? We just want to know, as Valencia has mentioned, and then you return it back to SANBAS. All of them, not one, all of them immediately. And then the blood bank people will discard. And then we are writing here the reasons why for hemovigilance, as Ms. Valencia has already mentioned. That's what I wanted to share, Val. Thank you. Let me stop sharing.
Okay. Thank you very much, Yvonne.
Let me see if there are other questions. Thank you, Val. Why did SANPAS take a decision last year to send defrosted FFP, not frozen plasmas?
Okay. I'm not sure where this is coming from specifically, but if it's possible, maybe we can know
let me start.
Okay.
Let me start. What transpired from my area, which is the city being okay. Most of the private hospital, they had a tendency, they will order plasmas, ne? They will order it for Valencia Nkambule. And then Valencia Nkambule does not use that plasma. They will take that plasma and transfuse it to Yvonne Nyakaza without notifying the blood bank. That was number one reason. And then the second reason, which was, I found it as the most important one, the reason why SANBAS decided to defrost the plasmas for the hospital, especially if you don't have a blood bank in your premises. If we are at the blood bank, we are issuing the plasma to you is frozen. If it's leaking, we can't see it because it's still in frozen condition. But if we defrost it ourselves, if it's leaking, we'll be able to quickly replace it for the hospital, so that instead of wasting time, the courier goes and collect and then found that the plasma is leaking, and then they need to come back, take another plasma. So it's a better way. And remember, SANBUS, we have plasma towers which we maintain on a daily basis. And so we defrost them in good conditions as compared to if some of the hospital I've had, some they put it in a what do you call this, a microwave. Some they let the water run, take longer. So all those kind of things. So that's a reason why we decided to defrost plasmas. But what we do, we scratch out the expiry date of a year because it's no longer frozen. So we actually, if you check the issue card, comparing to the plasma, you will see that there's a new expiry date written on the issue card, and we also write it on the label that the new expiry date now is after 5 days. I hope I've answered. You can add anything, Valencia, if I've left something. Val.
Hi, it's Dr. Shinners here.
Okay,
Thank you so very much, Yvonne and Valencia, for the presentation. It's really really informative, as I knew it was going to be. Yeah, so I do note some of our colleagues that are on the sideline having difficulties with their registration. So we will assist you with the CPD points and get that registration going for you. So thank you for that. But Yvonne, I don't know if that was fully answered. So what must happen with this fresh frozen plasma? Are you saying, from what you just said here earlier on, is that there are colleagues that take the frozen plasma, so to try to fast defrost it and put it in the microwave?
Yes, Doc, that's what I heard. When they are
Okay.
defrosting it, they will defrost it in a microwave.
Okay.
Yeah,
Hmm.
which
And
is
then
killing proteins.
there were a number of items that were presented during the course of the presentation. So I
Yes.
want to address some of those questions, please, and those queries that came up there. I see Mandisa Matupi is also agreeing that microwave is not a right process to follow to get the blood to room temperature, or at least to the correct temperature. What I wanted to say was from a question here that was earlier on with regards to the practice. When you say that, by condition, or sometimes we will say that we want the bloods to be sent urgently, so it's stat. But you mentioned, Valencia, that it comes with potential risks because you haven't necessarily gone through all the parameters. You'll send the blood as soon as possible, but then you continue to do assessments which might turn out to compromise the patient. And if you then try to reach the caregiver to tell them of that and their phones are not available, then again, further compromising of that patient's health. Did I sort of confirm that that's exactly what you said?
Yes, the reason that it compromises the patient, or there's a question around safety, is that we have not answered all the questions as far as compatibility testing goes. So we rush to give it to you, and then we remain behind to complete the test. And some things we can find out at the later stage or the final stage of the testing, that actually your patient, for an example, from the previous pregnancy developed anti-D, or okay, this one is not likely to happen because I would have matched them for RH, but let me say anti-K, which can develop just like anti-D. And then if that the donor's blood has the K antigen, then that anti-K can then bind to those donors' red cells and destroy them. So we must be able to reach you, or at least reach the ward where you are located, to give you that information. It's happened to me twice in 7 years at the blood bank, that I had to call a doctor after issuing emergency blood to tell them not to transfuse a particular unit. So it is a real risk that exists.
Yeah, and what's also important, thank you so much for that, Valencia, is you mentioned that there are bloods that are kept at the different hospitals, so in the fridges, maternity wards, theaters, or even the casualty departments, you're saying that there's also a risk that is associated with utilizing those bloods for patients that urgently need them. And are there any for instance, uh, what is it, mitigating approaches that need to be taken to make sure that the risk to the patient is limited?
Well, in that particular case, because with this risk and benefits, I mean, that's what we're always doing, right? So if you have a
Mm.
patient that is bleeding urgently, so that risk, which you cannot mitigate by knowing beforehand, right? So you will actually, when you are using that blood, that risk is already accepted. So, but what we try to share as much as possible, if you have that type of a patient and you are reaching for the emergency blood unit, rather take one and put it up. While that one is running, take a specimen and send to the blood bank for compatibility testing, right? For any additional units that you may need from that patient. Instead of saying, if you have four units in your fridge and then you go ahead and you use all four on that patient, or else you could have said, okay, while I'm using this one, then I'm sending the specimen to the blood bank for emergency cross matching. Because if you think about it, in that particular setting, you don't know, you have not tested the patient when you start that transfusion. We also do not know because we've not received a specimen for the patient. We can only tell you that the donor is O negative or is O positive, and that is it.
Mm. Yeah, and before I go to more of the questions, I remember at some stage, Yvonne, when you did a presentation, you were really concerned about how blood products are stored in the fridges, for instance. Some had them upright, some sideways, some in different ways. I just want to also just go there. I mean, it's not just about having a lot of blood available. There are certain ways in which the blood needs to be kept in those fridges and stored.
It's true, Doc.
I don't know. Also, Doctor, I've already spoken about that platform that we have, and I don't want to abuse yours. But again, you can invite Miss Nyakaza to come and do a talk only on the maintenance of an emergency blood fridge, on how the units should be stored and how they are checked on a daily basis to see if they are still suitable. Because the longer the blood stays there, for some donors, it can actually hemolyze and become unusable before the expiry date. So the colleagues that are working in the wards where an emergency blood fridge is kept, there are certain daily checks that they should be doing. And some of that is visually inspect the blood for suitability for use.
Excellent. At the start of the presentation, I mentioned to you that Professor Lundgren initially initiated this conversation around the fresh frozen plasma and how it's stored, defrosted. There are some questions related to that. And I know Prof. Lundgren has a hand up. And so, Tolakela, if you can assist unmuting Professor Lundgren, please, so that we are able to have her ask the question directly, please.
Thanks, Dr. Shinners, and thanks, Valencia, for your talk. I don't think you highlighted the BRB block on the ordering form enough. And because and it's a silly little block in the middle of the form, with all due respect. And I've said this to Sandbus before. You've got a huge block for urgent and elective and whatever, and a silly little block underneath for BRB. And BRB is blood on a returnable basis. It means in a hamper, and if you don't use it, you send it back as long as the hamper's sealed and the patient isn't charged if you're in the private sector. And a lot of people forget to cross the BRB block. Is it easy to bring it up? Because I honestly think it's incredibly important to save either the state or the individual patients in private.
Absolutely, Doc. I can share it again. It's just that already I was going a bit over time. If you look, because I finished round about Gora 2, and I was informed that you love the Q&A session and you need about 30 minutes of it. Yes, but I can absolutely bring it up. And also, we have a talk where we talk about BRB as well. So we can come back again and talk
No,
more
Valencia, please
specifically
do.
about
Yeah,
that service.
Thanks, Valencia. Please feel free to bring it up. It's quite okay. The colleagues here are quite engaging, and they are here every Thursday. I really want to learn and see how we can improve care to patients. So feel free to bring that up. In the meantime, what I'll do is I'm gonna put a question to Yvonne. Yvonne, so there are people that seems to be asking questions around how do you defrost the frozen plasma? Do you put it under hot water, running water under the patients? Are you putting it in a bucket of water, warm water? What is this? What is the recommended approach?
Okay,
Yeah, thank
okay,
you.
Doc. While Val is still searching for the correct place, okay,
Yeah.
the proper what I normally advise if you receive a plasma frozen, not defrosted by sunburst. The way to do it, you use a plastic Ziploc. You use lukewarm water, but don't use your hands. Don't use your elbow. My warm won't be the same temperature like yours. We differ. So you use a proper thermometer to check that it should be at least 37 degrees. Then you put the reason why you are using a plastic Ziploc, just in case if that plasma is leaking, it doesn't mess up the rest of the water. So you put it inside. If you don't have a plastic Ziploc, you can use a normal plastic, but I just recommend plastic Ziploc, that the little bit gas size one. Yeah, and then you thaw it. It normally takes about 40 minutes to 45 minutes if you are using lukewarm water. But in sunbaths, we have new plasma thawers. It takes about 15 minutes, especially for academic hospitals. And some of my areas, they use the plasma thawers. It's quick to thaw. Takes about 20 minutes, 15 minutes to thaw the plasmas. I hope
Okay.
I've answered.
And
And then
to
once
add
you're
to the
done, yes, go ahead. Go ahead. I should say that
Yes, I
also
wanted to
while.
say to add to what my colleague is saying, if you're
Mhm.
ordering plasma and you know that you want to attend to it, you can also use the comment section to specify, to tell the blood bank, because I understand
Good.
we have different colleagues from different regions, to tell the
Yes.
blood bank to thaw it for you. Because
Yes.
if you are thawing it with warm water, the thawer is the best instrument because it maintains the temperature of the blood at 37 as you put the frozen packs, which would, under normal circumstances, lower the temperature a bit. But with the thawer and the thermostat, it makes sure that the temperature of the water that is defrosting this blood product stays at 37 degrees. That is why it's quicker, more appropriate than at the blood bank.
Sure. Okay, so you're saying that you recommend that people, or they may ask the blood bank to prepare it appropriately before they have it sent to the hospital or the facility that requires the blood, or
Yes,
the plasma rather. Okay,
yes,
and then yeah, I see you have your screen opened. Would you like
yes,
to proceed and look at? I hear what Prof is saying. Do you see your BRB there,
yes.
small? Somewhere? Yeah. So please go ahead. Thank you.
Yes. So if you want to use the blood on returnable basis service, which is available at many blood banks around the country, then you would indicate here by ticking blood on returnable basis, then indicate the date and time, right? But the BRB, you have to use the blood within 12 hours from the time that the blood bank issues it and puts it in those BRB hampers, right? And there are two compartments where we can put 1 unit each, and then we also use cold and warm markers, or what we call indicators sometimes, because they will be able to tell us if this blood at any point was below the acceptable transportation temperature, which is between 2 and 10 degrees Celsius. Because even if the seal is not broken, but the markers are activated, it would mean that this blood is no longer suitable to be given to the next patient. Because what happens under normal circumstances, if blood was ordered and then not used, it comes back to the blood bank, we destroy it. But if we use the BRP system and it meets the required quality, and that's why I'm guilty of not touching on this, because then when we do the talk on BRP, we go into detail about this. And if it meets those standards, then that unit can actually be returned back into the blood bank stock and it can be used for another patient. There is a cross-match fee that is charged for the requisition, as well as a BRP fee. And what BRP is not, it's not a form of an insurance, because I once dealt with a hospital that says, we just in case, they were seeking BRP basically for all their orders, including plasma and platelets, which there's no BRP that's available for those particular products. Just to be clear, again, I am happy to come back, either myself or Ms. Nyakaza, to speak specifically to BRP, or we can speak about BRP and marry it to the emergency blood usage, whichever way works for you as our hosts and our colleagues.
Hi, Professor Langren. Would you like to have a follow-up question with regards to the BRP comment?
No, I just, we did an audit in my hospital, and we basically, a lot of our blood is ordered after hours for the next day, and there's an after hours, a specific after hours fee. So, which is crazy when it's for elective surgery or needed electively. So that was one area of cost, and the other issue was a lot of colleagues don't notice that BRB, block in the middle of the form when they're sure they're going to need blood in theatre or in ICU or wherever. And I saw another question in the chat. If a hospital doesn't have a platelet agitator, how do they agitate the platelets? I mean, surely SANBIS, with the cost of platelets these days, I mean, I know you said at the beginning your latest cost price thing isn't out, or I can't remember what you said, Valencia, but with the cost of platelets, is it not worth looking at, getting platelet agitators into as many facilities as possible?
Okay, I will start with the after-hour fee. So as of the 1st of Jan 2026, the after-hour fee no longer applies in the private sector, and it is to be discontinued in the public sector in May, right? I think maybe that's part of also the reasons why there's been delay in publishing the price list. So we can get it for you, but it's not the correct format yet, because there's a format that gets circulated internally, and then there's a format which is put online for the public and as well as the providers to access, right? And the one on the platelet shaker, first of all, there's no way of shaking a platelet or agitating a platelet other than to use a platelet agitator. So what we often say to the colleagues as well is that they should order the platelets when they know that as soon as the courier arrives, they will be putting it up, because when it's in transit, it is shaking. But the question of procuring agitators, I am not sure if we can answer that one. But we would have to then take it up to our management and tell them that we had this engagement and this is one of the questions that were posed. I'm not even sure if we can supply medical devices, or I don't know. It's a bit complex, so we'll have to take that one up.
Thanks, Dr. Shinners. I think I've said enough.
Thanks, Professor Langren. Yeah, always passionate for patient care. Thank you so much. We have a hand up, Siatile Mofokeng. I see you've been unmuted, so please do go ahead and raise your question directly. Thank you.
No, thank you so much, Chair. It's Dr. Mufokeng from Sebokeng Hospital. No, I just wanted to check with the team because I know that we have webinars. Well, they do have webinars every Friday. And I'm wondering, because they do send us in the public sector, they send the links there is a group in well, my hospital specifically, where we have a group for the blood and blood users committee. And I'm wondering if then would it not be possible for them to share the Friday webinars, because a lot of the questions that are coming up are actually addressed in the webinars that are, conducted throughout the entire year. And if I remember well, it will only be like on public holidays or during December, where they are not actually offering these webinars. So I'm thinking that it would be a good idea to also share with the Nkanyezi team, and maybe from my side to say that our Yvonne actually comes regularly. She even has a session tomorrow, that it's not necessarily restricted to only our employees. Should it be that we can then combine with the private institutions that are near us, we are more than willing to do that, so that the more the merrier. I think blood is quite a high cost driver in all our institutions. So it would be important if we then are able to collaborate and we can have a session that, incorporates a lot more people, so that she doesn't have to then be going up and down, between facilities if we are near each other. So I think, yes, thank you so much. The session was quite informative, and we will continue to join the Friday webinars. I think there is already one scheduled for tomorrow, but she will be on site with us. So I think it's important as well that we try to collaborate with each other to improve the services that they are offering. And it helps a lot when they are on site, because actually you'll find that the people that are, in the webinar right now are not actually the people that actually, use the services. It's not the people that are next to the patients. So it's important that the people that are next to the patients are the ones that actually join and gain much more knowledge to make sure that the service is efficient and the patients get the best possible quality care. Yeah, thank you so much, Chair. Thanks to the team.
Thank you
Yeah.
so much for that comment. I did touch a bit on the lecture series, but I didn't want to talk too much about that one when we are invited or we are hosted on another platform. Just I didn't want to be naughty. But it's absolutely, we share as much as we can. The more we collaborate, we learn from each other's
Better.
experiences. We are even more richer and more educated and a better position to take care of our patients and their safety. So we welcome collaboration, we welcome networking at any opportunity that is made available.
Okay.
Yeah.
Val,
Go
sorry,
ahead.
Doc.
Yeah.
Sorry, Doc. Tomorrow it's Dr. Vessels talking about patient blood management. But there's a question here saying, evening, the blood arrives cold in hospital. What's the right way to warm it before it's given to the patient? There's one thing which I can say: don't wrap it, don't wrap a unit with a paper and put it between patient thighs. That's what I always say. But there are actually, you can transfuse blood slowly, as Miss Valencia has mentioned, 4 to 6 hours. Cold as it is, you don't need to warm the blood. The only reasons or indications to warm blood is when it's massive transfusion, neonates or infants, hypothermic patient, transfusion via central line. And then if the blood bank notifies you that your patient has high titer of cold hemagglutinins. What we mean is as follows. When I was testing the patient against the donor, remember we test in different temperatures. Remember Ms. Valencia spoke about certain things which we do when we decide to do electronic cross match or not, is things like that. If your patient has antibodies, we have to do those different tests. We need to do those different tests. So if the patient reacted in cold temperatures, we will notify you. That's why it's very important as a clinician, you need to write that contact number under that place where it's written. You saw Ms. Valencia wrote there, Dr. Vilakazi. There, you write your cell phone number so that is easy for for us to contact you. Yeah, I hope I've
Good.
answered.
Yes, you just forgot one type of patient, the one who's hypothermic. So if your patient is already
Yeah, thank you.
hypothermic,
Yes,
yes.
thank you,
And
Val.
then to warm the blood, you must use a validated blood warmer.
Yes, with audible alarm.
Yes.
Audible
Yeah,
alarm. Ladies, thank you once more. Thank you so very much, Yvonne and Valencia. I just wanted to say to Dr. Mafokeng, yeah, I am actually going to be in the Val sometime next week. I'm going to come by Sebokeng Hospital. That's where I did my internship in my community service. So yeah, it's good to hear that you are doing exceptional work and that you're still continuing education. And you're absolutely right. It's best to collaborate, no matter which part of the healthcare industry that we are in. I mean, on this platform, there are people both in and outside of South Africa, private and public sector from various disciplines. The idea is that we ultimately have the best interest of the patients that we all get to serve and have the privilege of treating on a daily basis. So, yeah, we always look forward to collaboration. So, thank you for that. Ladies and gentlemen, if there aren't any further questions, I see that there are a few comments there, assistance that is going to be required. Oh, Dr. Mofokeng has a hand up again. So, we will come back to our colleagues that need assistance with their CPD points. Dr. Mafokeng, just one more. You want to close it out, and then I will just wrap up the session this evening. Thank you, Dr.
No,
Mafokeng.
no. Yes, thank you, Doc. No, I wanted to say it would definitely be a pleasure for you to come through. I think Yvonne and the team, they do have my email and my contacts. So if you are to come through to the Val, then we can meet up even with Mr. Moloi, the general manager at Nkanyezi at Sebokeng, so that we can see how we can try and streamline. We work a lot with him to try and make sure that we are making sure that our community is taken care of. So please do contact me. I think even the nice thing about Sandbus is that it brings people together. So even previously, they have a Jehovah's Witness, what do you call it, committee, where they are then have requested that they come on site and they do in-service training with understanding of how to manage Jehovah's Witnesses, which is a very difficult, aspect to understand for a lot of medical and nursing staff. So even with them, we have a good relationship, and I think it will benefit as well for us and for the community, for us to have their contacts, and they can come on site and discuss with our clinicians and nursing staff. So please do come through. I will be waiting on that. Thank you.
Yeah, that's wonderful. Thank you, Dr. Mafokeng. And indeed, that was a question that I anticipated when it comes to the blood transfusion and the protocol followed where it comes to patients from a Jehovah's Witness point of view. However, we do have next week one of the presenters from a legal point of view. We've had them before. The company used to be known Norton Rose Fulbright, but they have split away from the international body and have now changed the name to Danae's. So they will be here next week. So we will be having discussions about the legal matters when it comes to the practice of healthcare. And one of the directors will be presenting, and he was quite effective. I think he speaks more like a doctor than many of the doctors that do actually speak, and in terms of his knowledge and how to help us mitigate and navigate this litigious landscape that we find ourselves in. Colleagues, thank you again once more for this. Your attendance this evening. Valencia, you did so well. Everybody, I'm sure, is going to put up their hands. Can you see all the congratulations and the appreciation? And that is the spirit of everybody that participates here on the Clinix Health group webinars every Thursday. You see, I told you it's nonstop, right? And so congratulations to you. Yvonne, we know you're there and we appreciate everything that you have also done. Colleagues, have a blessed evening. I have no electricity here. Telcom decided to switch it off 10 minutes before this webinar started, so my video is off. But I do appreciate the fact that you all stayed on to the very end. and we will ensure that whatever other comments and assistance that's required from colleagues in the chat will be attended to. So have a blessed evening. And Yvonne, Valencia, thank you once more and have a good evening too. So good night, everyone. Thank you.
Thank you, Doctor. Good night, colleagues.
Good night, everyone.